Welcome to Health System CIO's interview with Chuck Barkey, Associate Vice President for Inpatient and Ancillary Technologies with WVU Medicine. I'm Anthony Guerra, founder and editor-in-chief. Chuck, thanks for joining me.
Thank you for having me. I look forward to the discussion.
All right, Chuck, so let's start off with a little bit about your organization and your role.
Sure. So, I myself, as the Associate Vice President for Information Technologies, that I focus on inpatient and ancillaries for the entire health system, along with enterprise imaging, is my day job. My afternoon and evening job is I function as the IT senior leader for six hospitals in our northern zone currently.
Okay, so I think we're going to focus in today on some of the imaging stuff. And tell me about your background in sort of imaging. How I guess you came to it from the IT side, as opposed to the clinical side. Some people get to it that way. But tell me about your background in imaging, sort of how things were, and then how you see the evolution of imaging. We'll start with that.
Sure. So, honestly, I came in from telecom on the IT side and had my first opportunity with a larger academic center and integrated health system out of Pittsburgh, PA. And I was hired to be a senior PACS IT professional. And we worked with a vendor that we created our PAC system and then sold it off. And we worked to create basically workflows while the vendor now owned the PAC system. We continued to create software in my department and we would roll it out for the entire health system for workflows that may not necessarily be something that would want to be sold as an option, but they were specific to the health system that I worked for at that point in time. And so, you know, going along that front, I also was constantly pushing the vendor to improve their pack solution on where back at that time it was all physical servers and workstations where now we were pushing them to become a virtualized environment and take advantage of the virtualized space. And as I was leaving that organization, we were starting to push vendors towards cloud based solutions in enterprise imaging.
Okay, so I mean, how would you describe sort of the traditional approach to imaging in a health system and where we want to take things? I mean, and what's the goal? Like we're trying to make image sharing easier on the clinicians, make it easier on the patients, and improve clinical care. There's been a lot of challenges in that space with people walking around with discs and sort of clinicians not being able to see images where they want to see them, when they want to see them, especially patients from other health systems. So, if you want to sort of just take me through that world, which still exists in a lot of places, and where we're trying to go.
Sure. So I can tell you back in 2008, we created, well, probably was closer around 2010, we created a software package for, at that time, a 10 hospital health system that allowed us to share images electronically across, at that time, again, it was 10 different disparate PAC systems and be able to share across the HIM teams, the PACS teams, the radiology departments to be able to share images across since we were on different PAC systems. Here with WVU Medicine in 2017, we started our goal towards having one PAC system. And so by 2019, we had approximately 13 hospitals as one PACS vendor, and every acquisition across that time period at their go live, when we bring them on to Epic as our EMR, we've also brought them on to Fujifilm as our PACS and enterprise imaging provider. And so currently we're at 24 hospitals and everyone uses that same tool. So there isn't that same dependency of a third party app to try and make them all communicate. Everything actually happens internally being on one PAC system and one workflow. And we have our 25th hospital coming in April of 2025. Now, with that said, that doesn't help you getting images and CDs and DVDs and having to worry about delivery and whether it's the United States Postal Service or FedEx and shipping, along with carrying VPNs to try and transfer to other hospitals or using third-party products. Now, with that being said, we still utilize a third-party product, but we're transitioning from one. And on the first week of December, we'll be moving to Intellarad's Ombra software client. And the big goal that we want to find from that is not only for there to be savings with being able to electronically send to anyone the images that are required for the HIM and enterprise imaging environments across the hospitals. But what the beauty is it also integrates with our Epic and the MyChart environment that we have that is on your mobile device. So literally the patient will now be able to download their own cases and images and also send them on to their own physicians, whether they're in-house or not, by just sending to an email address or something along those lines.
Okay, so the strategy way back to 2019 was we're going to be on one PAC system, and that was across all the ologies. So everybody's on one PACS, cardiology, radiology, dermatology, whatever.
Not that was across radiology.
Okay.
And in 2021, at the height of COVID, we actually moved towards a digital pathology platform. And that has also since been acquired actually by Fujifilm. And so pathology now being digital pathology is a system standard across the entire health system. So we don't have different platforms. And we do have one cardiology system, but it's outside of Fujifilm at this current time.
Okay. So it's not necessary. The ultimate goal isn't just to get one PAX per ology. We can do better than that. You're saying we can use the same
Yes.
PAX across multiple ologies. Can we cover everything, or are there certain specialties in medicine that they say, no, I'm different and I need a very specific PAX to deal with the images here, and so I'm not going to go on what you've got everywhere else.
So, when you look at the enterprise imaging, there is the opportunity that there is a cost savings when, of course, you can try and have one system for all ologies. But with that being said, you also want to be able to have a best of breed approach. And so that's ultimately what we do with our VNA, the vendor neutral archive, which is also a Fujifilm product. That allows us to be able to put a third party specialized application that, let's say it's for cardiology in their PAC system, we still have one standard enterprise imaging repository using that vendor neutral archive. So that even though the specific physicians working within that workflow are using the best tool for their practice, we're still storing those images in our vendor neutral archive. And that's how we can get a best of breed approach, whether it is pathology or it is radiology or cardiology or wound care. So
Yeah, and this is sort of the classic tension or the classic balance, right, that we're trying to strike, which is to get as much standardization and commonality and reduce complexity as much as possible from an IT point of view, while still satisfying the clinicians who may want to use a particular tool. Where do we have to say no? Or can we say no? And where do we get to say yes? And where do we strike that balance? And you said there are ways to do it, such as the VNA. Makes you be a little allows you to be a little more flexible and still cover yourself on what you're trying to do on the back end. You mentioned the Intellarad product. These are all ways of dealing with that sort of tension in healthcare. Does that make sense?
Absolutely. And that's ultimately what our goal is. I want to give that best of breed approach. And, I've brought up a couple times around that there are cost savings. The number one priority in healthcare is always going to be healthcare and what's best for that patient and for that physician with that patient. But with that being said, a lot of times products can do the same exact thing as another product. And if you have an opportunity for savings, we should be being able to do that. But however, whenever there is that missing delta and it only does 50% of what the other application does, that allows us to provide better care, we absolutely have to leverage that ability and still be able to provide that the referring physicians and the primary care physicians can get access to that enterprise imaging environment, which is what was a limitation 10, 15 years ago, because they were all in different pillars, radiology, cardiology, labs, so on and so forth. We're breaking down those walls and those barriers by allowing these systems to communicate with each other, and that VNA for us is the primary successful point for us that allows us to handle any imaging. We even have what is called a sexual assault nursing examiner workflow program that deals with video and PDF documents, and that we are aligned with the ED department and the same nurses. So, it's a workflow you don't ever want to use, but unfortunately, we need to have that ability, and we're able to do that in our environment.
Okay, so we on the EHR side with Epic and the dynamic there, at least the prevailing dynamic of the last 15 years has been there will be no best of breed on the EHR side. We're not doing that. We're going with an enterprise system. Epic has been very dominant. When an Epic system acquires a hospital, there is no conceivable scenario where that hospital stays on some other EMR. They're coming off it, they're going on Epic. But we don't have the same exact dynamic in the PAC space where there's sort of that dominant enterprise vendor, or maybe we're getting there. I'm not sure, and it is no question that you're coming off it. Now, you said you were doing that with your acquisitions, and I've interviewed other people who were doing that. I've also interviewed people who are taking much more of a best of breed approach and saying it's very difficult to deal with some of these. I'm thinking of these physician groups. Let's say you're acquiring a radiology practice. You could get a tremendous amount of pushback if you're telling them you're going to change your PAC system. And that might create an issue there. And so I've heard people say, we're going to integrate on the back end, let the users use what they want. Much more of a best of breed approach. What are your thoughts around that? How sort of the EHR dynamic is not quite the same in the pack space.
So, what I would say is, I think every health system or integrated delivery system in today's world has a choice of how they want to operate. And the former health system I came from very much operated that way, where we would just interface things. And we also did it with EMRs. They had three separate EMRs working in that world. And and now they actually recently they've chosen to go to one EMR. And so from the enterprise imaging side, I don't I think that you lose so much benefit by having multiple PAC systems versus one singular PAC system. We've been able to garner the support of our leadership. It's a part of our sales process that as we've acquired these types of radiology practices, or let's say, an orthopedic surgeon or something along those lines, it's communicated up front as a part of the sales agreement that they will be going to our standards. And if they're not interested, some have, that's been a deal breaker. But for the most part, we've been able to hold on to that standard, and then we're able to deliver on that same expectation, and not to use a food terminology, but that same McDonald's French fry that our CEO loves to use as an example, that no matter any of our 24 hospitals, they want you to see the same report. They want you to see the same image. They want you to see that gold standard. And we're able to deliver that. When you start getting outside and get into best of breed, you're now putting technical solutions in the middle that cause a lot of times performance degradation or breaks. And then it causes you a lot of IT issues, which causes a lot more staffing for IT, and where we could be using that for more nurses, more lab techs, and so on. So we try and run a thin IT department within WVU Medicine. And when you compare us to our peers, we're very low on that standard scale. About within We're about in the bottom 6% of Epic clients with the amount of size of staff that we have, but yet we get an awful lot out of them. We're very proud to say that we're MRAM and OMRAM level 10s with Chime. We are an Epic honor roll hospital at their second highest level, and hopefully next year at the highest level for 7 straight years. We're a HIMSS level 7 organization for 23 of our 24 hospitals, and we're hoping by middle of next year we're going to be 24 out of 24 hospitals. And so we got an awful lot out of this group, but it's because we have these standards in place that we can accomplish that.
Yeah, so it's very interesting. So you must have convinced the CEO, the board, the CFO, the powers that be, who are going to be leading, deciding who they want to acquire, who they may want to acquire. You must have convinced them that this is important and this is beneficial in the long run, because you could certainly have the dynamic where they say, listen, Chuck, we're acquiring this radiology practice. They have 300 radiologists. It's strategically who we need, fits well. They're not going to go to your PACs. Make it work. Right? You could have that, and then you
We
sit
could.
there and say, "We'll do our best." But you've convinced them. You said this is the way it is. So you've convinced operational leadership that this is a worthwhile stand to take, correct?
Absolutely.
And that's how you can operate and be thin. I mean, I guess it would be the conversation might be something like, "Well, if you want me to acquire this practice that's on a different PACs and they're going to stay there, we're going to need to staff up a bit. We're going to have to create integrations. They're going to have to be maintained. It's and that's forever, right? So
Yes.
that's so tell me any more you want to add on that whole dynamic?
No, I mean, what I've often said is, you could pay now or you could pay a lot more later, you know? So,
Yeah, and that's exactly what I think it is. But sometimes it may be easier to take that short-term win and say, okay, everyone's happy, we've acquired them, they're happy, they get to use what they're using, and IT in the background's going, oh boy, you know?
yep. Oh, absolutely. But I not only applaud our C-suite, whether it's our CIO, our CEO, and all of the groups, the CFOs, if you said chief quality officer, so on, of aligning on best practice of what we were doing as a health system. But then also my colleagues across radiology and radiology and the labs and so on, that we all have that same vision. We want to be able to drive the best we can from the technology and get the best that we can from the vendors that we use.
All right, so you mentioned the term pay now or pay later, which is a great way to look at it. Your approach is a pay now approach. It's not a pay later. Maybe you're saying you pay less if you pay now. So that would make sense. But pay now means migration. It means that the entity being acquired, whatever they went on, they could have been around for years and years and years. And these are massive files. There's massive amounts of data, which is one of the reason
Yep.
people are sometimes happy not to deal with that and to deal with an integration rather than a migration. Um, so I've heard people say, listen, it's something you have to learn as you go and you get better every time you do it. You're going to be much better at it like anything else. The 10th, 15th time, you may be a little rough the first time. Is that kind of how you see it? And just tell me your thoughts around migration and doing that well.
Oh, migration is the dirtiest of all jobs. Migration, I've often said, in IT, we're professional dirt movers. You take dirt from here and you move it over here. But then all of a sudden, when you're doing migrations, you're no longer using trucks, you're using your hands. And so it is a muddy situation. And to be very honest, you do get better as you go along. But you know what? And what we've also found is the amount of effort that goes into it manually when you do it yourself versus what you can accomplish when you find that right vendor and whenever they're doing them consecutively with you. So, like, I have 7 different hospital migrations going concurrently right now as we still get them completed. And we're usually right around the 12-month mark, depending on the size of the hospital. I mean, if it's a 300-bed hospital where they have, they average 150,000 exams a year, or say 500,000 exams a year, and depending on how long, it may take a little over 12 months. But I mean, what our number that we try to estimate right now is about 12 months. And that's where my team does a fair amount of the validation work, the detail work, but we allow the vendor to just do the migration and allow us to do the detailed work. So, and that's helped us a lot. And it's a good approach. We have a fantastic vendor that works with us for that, and a great relationship. And not to mention, they also provide a lot of tools to us that helps us on day-to-day operations, and especially in the migration environment. So,
Right, and this is a consulting company or a services company. This is neither PAX vendor. We're not talking about the one you're
right,
coming off.
neither
We're
vendor.
not right. It's a special company that helps specifically with PAX migrations.
All PACS migrations and solutions within an enterprise imaging environment.
So you find if you're going to go down the strategy you're going, you need to find that solid partner. And then you're
Yes.
again, they're not just going to be a one-off. It's going to be like, all right, if you can do this for me, we're probably going to keep acquiring stuff. I'm going to keep needing you. So it really you can create that nice partnership where you start to learn each other and now let's do it, right?
Oh, absolutely. I would say they're probably, if they're not my number one favorite vendor to work
Mhm.
with, they're in the top three.
Do
So,
you worry about a vendor like that being able to handle the low, you pick up a hospital and they've got other clients and they could get hit with a couple of big projects at one time and then you want to drop a big one on them. I mean, are there capacity concerns occasionally?
so I don't have it with this vendor
Uh-huh.
because I give them about 18 months notice when I'm aware
Okay.
of an acquisition that is of significant size. I give them plenty of time to ramp up and get ready to reserve resources for us. And where if they would have another company come in, they would hire new staff for them. But I've already reserved
Yeah,
the individuals.
makes sense. Makes sense. You get ahead of it. What are your thoughts around maintaining clinician satisfaction for the group that is going to be moving on to your PACS, to a new PACS to them? It's a new PACS to them. And I don't know if this vendor you talk about, if they do training. Who trains up the newly acquired users on the new PACS they're going to be using?
Sure. So I have an amazing team of enterprise imaging analysts, and we also have a very, very strong and amazing team of trainers, IT trainers within IT. Which actually that department also reports to me as a part of the inpatient training, because we do all the training for Epic. We also do the training for PACS and cardiology. But with that being said, there's always some additional higher level that if you're not a radiologist, that you may not know how to do something. Our PAX vendor is very good at training my team, but they have a very strong program of, we know how much it costs to bring someone on site, and we could set up at any acquisition where we might say, let's bring in a Fujifilm trainer for this particular space with this specialty, let's say neuro, and they'll send someone in who has 3D and neuro specialties to show them all the tools specifically. And we have a great, once again, relationship. I really think that the key to having a strong IT department is having that same equal strong relationship with your vendors
Hmm.
and strong relationship with your physicians. And so whenever they say they need something, we listen, and we've got everyone pretty well trained that we can do this on a schedule where we know about 6 or 8 months in advance before something's coming, so we can budget for it appropriately. So it's not constantly an unfounded request that was unbudgeted.
Hmm.
And so we've been able to accomplish those kinds of things pretty well. We also have a strong enough relationship with our vendors that, and this goes past Fujifilm or any of the others, that if we absolutely need some professional services, that a lot of times they'll send them in. With the contracts, if it's a one-time thing, quite frequently they'll send someone in and just say, hey, let's go ahead and clean this up, and then we'll look at that in our next maintenance agreement on, how can we improve this.
Right, right. Very good. One of the things I hear, with IT folks in healthcare and different positions is the importance of having those deep relationships with the users, the clinicians, and understanding as much as possible what they do. What do you actually do? Um, how have you tried to make yourself knowledgeable? Because these are very nichey things. I mean, digital pathology. I mean, that's so how have you and your team, or you and coaching your team, tried to understand the clinical operations as much as possible?
So one thing that's really beneficial about being an Epic shop is of our size, being now 24, very soon to be 25 hospitals, you are siloed on the information system side. So that's the Epic side. So if you are in radiology, they have the RIS, which is Radiant. And if you're cardiology, you're Cupid. And if you're labs, you're Beaker. And then they have Beaker chemistry and Beaker pathology. So what you're able to do is with Radiant, a lot of our radiant analysts are former grad techs. And in cardiology, they're former cardiology techs. And in the Beaker environment, we have chemistry and pathology former techs that are working there. So they already know how the physicians are working and what had been requested of them. And they all the way down to almost a specialty view of each physician, whether depending on the area. So, how we're able to have those relationships is many times these are people that have been in operations for 15, 20 years, and they just were like, I've always enjoyed the IT part of the job and the operational. Is there something outside of clinical care for me? Because I think I still want to work, but I don't want to keep doing this. And we provide them an avenue to get and spread their wings, because our health system views that we hate losing staff. I don't want to lose that 15 years of experience to another health system. So I provide them an opportunity, and then we can bring someone else in and get them in their early parts of their career and prepare for them for hopefully 5, 10 years down the road also. I think the other key is to ensure that you're not poaching, and that's just having strong relationships. My teams will not go and reach out to operations when we have an opening.
Mm.
It's required that when that person goes and applies to us, the manager or the director of that department will reach out to the operational leadership and say, hey, I wanted to let you know this person applied and you should have a talk with them. If you're okay, we'll interview. We're going to go through the process, no guarantees, but are we good?
Mhm.
And that's what we've been able to do in each of these areas. And many times operations has been saying, yeah, we think we're going to lose this person. I think it would be a great opportunity so that we can retain that talent. And that's where we're very lucky. And whether it's in the ED or in the ORs or anesthesia, a very specialized environment, we've been able to accomplish those things.
That's wonderful, Chuck. We're just about out of time. As a final question, I would like to ask your best piece of advice to someone in your position at another health system. Let's say they're much more siloed on the imaging side. They really haven't made a lot of progress, but they certainly understand that they need to increase sharing. Obviously, there could be a million different scenarios for the type of environment they're coming from, because there can be any kind of configuration or mix of different PAC systems. But for someone who wanted to move towards an enterprise imaging environment, what would your best piece of advice be?
For sharing images internally or externally to the health system.
Well, I guess that take it as a step one and step two, right? First, we're going to
Sure,
start internal and then maybe someday do external.
sure. So internally, I would work with operations to ensure that if it's a small health system or a large health system, that you have the governance in place so that that same governance and process and workflow can be followed at every single location without exceptions, unless it's an absolutely where you can't meet a workflow because of a certain hospital. But in this type of environment, they would be few and far between. So I would ultimately say that it would be about starting the governance within the HIM and enterprise information management environments. And then from there, finding the tool of exactly what you're trying to accomplish. There's freeware out there that allows you to send a study from your server over to someone's email. It could send it to them with a direct connection, VPN to VPN. There's all different ways to do it. There's all kinds of third party products that cost money. And so I think after you would have the governance, you would have to look at what are you trying to attain. For us within our health system, we wanted something that would help improve our process, which would get us away from CDs and DVDs and having to buy burners and printers and having to have an account with FedEx that costs 250 to $300,000 a year across the health system of shipping cases. And so as you determine what those requirements are, that's how we ended up coming up with our solution. And the best way that I could come up with it was, let's put it right in our patient's hands, right here on their phone. So when they're in my chart and that doctor says, I'm a third party specialist, all they have to do is go right in and go ahead and send it to the phone number or to the email address that clinic wants, and it's completely out of everyone's hands. It's being done right by the patient themselves. That's where I think, I'd like to think that we're not leading the way. We're way behind by getting to this solution. But with that being said, um, I think it's better that we consider that the more we can allow our patients to do and then only help the ones that can't do it is more beneficial, or who may struggle. They can do it, they just need a little education and training. And our help desk will be prepared to help each of those as they call in with those types of issues. So, but yeah, I think healthcare today is more about putting the power back into the patient's hands.
That's great, Chuck. That's perfect. I think our audience is really going to enjoy it. So thank you so much for your time today.
Oh, thank you. And it was a pleasure meeting you and getting to talk with you today.